Hello and welcome to my presentation entitled Women's Experiences of Their First Pelvic Exam, an Arts-Informed Narrative Inquiry. Before I begin today, I'm honored to acknowledge the support of my co-authors, Dr. Schwind and Dr. Schindel-Martin of Ryerson University and Dr. Menenko Rankin of Nipissing University. Finally, I must acknowledge that this inquiry would not have been possible without Andrea, Celeste, and Claire, the pseudo-named co-participants of this inquiry. My journey began with a question, or as it is known in narrative inquiry, an inquiry puzzle. How do women experience their first pelvic exam? This inquiry puzzle came to me through my work as a primary care nurse, and I began this inquiry by looking inwards towards my own experience. To begin, I told the story and engaged in metaphor reflection on my own first pelvic exam experience. I reflected on the impact my experience had on my healthcare seeking behavior, and I wondered if I was alone. I further considered, as a healthcare provider myself, how I could do better for patients in my care. These reflections invited a more fulsome exploration of the landscape of pelvic exams. And using the structure of the theoretical framework of narrative inquiry, I briefly reviewed the history of pelvic exams in North America, the modern context of public health incentive policies in primary care, as well as the physical setting of pelvic exams in Ontario, Canada. Next, I examined the literature, where a synthesis of 35 titles revealed that for many young women, the first pelvic exam is a source of anxiety. Women avoid these exams due to fears of pain, embarrassment, shame, awkwardness, concerns about a lack of confidentiality, or discomfort about the unknown aspects of the experience. These concerns are based in the reality of negative pelvic exam experiences. Pelvic exams have been described by women as a dreadful thing and the price you pay for contraception. Other women describe pelvic exams as shaming, objectifying, and even abusive. First pelvic exams are considered a turning point in women's healthcare journeys, informing how women go on to trust healthcare providers, access care, and even perceive their own bodily autonomy in future. Scholars in the literature emphasize to healthcare providers the significance of patient education on the importance of pelvic exams. And certainly such educational efforts would meet a demonstrated knowledge gap on behalf of young women represented in the literature. However, for their part, young women interviewed did not ask for more education in the literature. They instead valued dignity, respect, communication, and consent from their healthcare providers. I noticed that much of the literature was focused on the healthcare provider's perspective. Ultimately, I found no literature which addressed first pelvic exam experiences from the perspective of women themselves. I further found no narrative research which invited women to tell the stories of their first pelvic exam experience. The missing puzzle piece is women's perspective. Identifying this gap in the literature and with research ethics board approval, I advertised to invite 3 young women to tell the stories of their first pelvic exam experiences in full using metaphor reflection. Their stories moved, challenged, and invited me to more deeply examine their experiences, and I am proud to have earned their trust to share their stories with you today. Upon manual transcription of these interviews, I entered the interpretive process of composing the stories. To bring the stories into chronological order, I arranged their stories in sticky notes on my office floor, using quotes and visual descriptions in the words of the co-participants. All the while, I listened to the audio of the interviews over headphones, noting the rhythm and cadence of their voices. Each co-participant approved their crafted story. Then, I traced yarn across each story arrangement to identify emergent narrative threads. As I continued to immerse myself in the inquiry, I discerned how certain narrative threads resonated or coalesced with others across the stories. And as I examined these relationships, narrative patterns emerged. Initially, 6 narrative patterns became apparent: trust, voice, hope, gaze, resignation, and objectification. As I surveyed these patterns within each story of experience, I identified how each pattern cascaded with the others. Again, I noticed coalescent meanings. Hope, objectification, and gaze informed the larger pattern of trust. Objectification, resignation, and gaze informed the larger pattern of voice. I distilled 6 emergent narrative patterns into 2: trust, and voice. It is on these narrative patterns that I conducted my analysis. And for my analysis, I used the theoretical framework of narrative inquiry, the commonplaces of narrative inquiry, in conjunction with a critical feminist theoretical perspective. Equipped with these tools, I moved into fulsome analysis of trust and voice. Trust and voice are closely related narrative patterns. Both are relational in nature. Trust grows in an environment of mutual respect, where power is shared and a sense of comfort and safety are fostered. It is in a trusting relationship where voice flourishes. Voice is an expression of our humanity. Whether it is heard is a reflection of power. Both trust and voice are couched in the historical context of medical paternalism, which begets women's mistrust and silence with healthcare providers. As my analysis revealed, this context is very much alive today. To explicate the findings of my analysis, I briefly revisit Andrea's, Celeste's, and Claire's experiences as distilled in their metaphor reflections. Andrea's sense of betrayed trust during her pelvic exam left her feeling like a nameless, faceless person in this revolving door of a system. Both Andrea and her healthcare provider were dehumanized by this experience, and Andrea's voice turned inwards as she internally protested the indignity she experienced. Analysis revealed that women's fear of violence, judgment, or prejudice while seeking in care informs their silence. Women's silence is therefore a protective measure, reflective of mistrust. Mistrust further causes women like Andrea to underutilize healthcare services and lower their expectations for their ability to trust healthcare providers in the future. Furthermore, dismissal of women's voices causes feelings of isolation. Indeed, Andrea expressed feeling lonely after her pelvic exam and zoning out at future appointments with her healthcare provider. Andrea's metaphor reflection gray is a representation of her sense of being stuck in an oppressive system where she doesn't have a choice. No matter how she tried to find her way out of this loop, her brightly colored footsteps blend together to become a blur of gray. When analyzing Andrea's experience of trust and voice within the literature, I came to understand the significance of power, respect, and dignity in establishing trust. Without this, voice cannot flourish and moves to the internal space of thoughts. Conversely, Celeste's happy, satisfied emoji reflected her experience as an overall positive and inviting one. Celeste engaged in positive self-talk to convince herself to go through with her exam, and while she laid on the table awaiting the procedure, she told me, "I assumed they knew what they were doing. I just did what they said." In my analysis, I connect Celeste's expression of unequivocal trust in her healthcare providers with the historical roots of medical paternalism. Analysis reveals the dangers of such an approach. Resignation and compliance may allow women to receive care and improve their health, but it comes at a great risk. Blind trust seems to make consent irrelevant, reinforcing women's submission to power over them or paternalism. This effect silences women's voices to the internal space, which may continue in a trend in future. Unqualified trust can be misplaced, and women's silence poses a risk for unreported adverse events, among others. Now, Celeste was fortunate to have had a positive experience with blind trust. She had a respectful encounter in a safe environment. She was able to move on in her social relationships without a sense of isolation and move forward with resilience for her future healthcare interactions. Analyzing Celeste's experience brought me to reflect on the shades of trust which are so often accepted by healthcare providers. Finally, Claire's experience brought together a duality. She was comforted by her healthcare provider through her painful first pelvic exam, reminding her of when her cat comforts her when she is in pain. Claire's trusting relationship with her healthcare provider was based in respect. Within this relationship, Claire was heard and believed and made to feel supported through the procedure with power and control in her own hands. Despite a respectful experience and their trusting relationship, when Claire's healthcare provider asked her how the pelvic exam went, Claire told me she defaulted to politeness, saying it was fine. "It is what it is," Claire says. Her healthcare provider listened to her and did what she could to make it better. Claire's choice of silence was informed by her understanding that this undesirable exam was yet necessary. This nod to paternalism, in the end, informs my understanding of women's voice. Silence is a result of the evocation of paternalism. And Claire goes on to develop deeper trust in her healthcare provider, as well as a sense of relief in being heard. Analysis of Claire's experience told me about the power of respect to soothe pain and discomfort. And yet, even still, I recognize voice may not always bloom out of a trusting relationship. Generations of women's internalized dismissal is difficult to unlearn. For this inquiry, Claire's story is as close as I get to a hopeful ending. Still, I realize there is much work to be done. First pelvic exams are experiences where trust and voice come together, perhaps for the first time in a young woman's healthcare journey. Narrative analysis of this inquiry demonstrates that after their first pelvic exam, young women live with the impact of how healthcare providers value their sense of personhood, dignity, and consent. Because healthcare providers are in positions of power, these impressions are influential to young women's internalized beliefs about their personhood, dignity, and consent. When women mistrust healthcare providers and their voices are silenced, it becomes a difficult cycle to break. This affects women's healthcare and social relationships. As historical review over the last 150 years has shown, women have long been disrespected and dismissed by healthcare providers. This fosters women's mistrust and silence. These women's stories show that dismissive first pelvic exam experiences still occur today. These experiences matter. Clearly, we still have work to do. To improve first pelvic exam experiences, healthcare providers must earn the trust of women and listen to their experiences. How can this inquiry support such efforts? Well, I believe that empathy is the product of the transformation of life experiences into knowledge through critical reflection. It is only through critical reflection that meaningful change can be realized. And with the new knowledge I've unraveled in this inquiry, I knit a new narrative. I invite my colleagues and peers to join me in critically reflecting on the narratives of Andrea's, Celeste's, and Claire's experiences. I implore my colleagues to be present with themselves and the women in their care, uphold the dignity and respect of young women in order to earn their trust and honor their voices. The historical context of medical paternalism is alive and well in the 21st century. As healthcare providers, it is our obligation and our duty not to let this continue. Women's survival depends on our actions. The narratives of Andrea, Celeste, and Claire may serve to inspire and inform the provision and policies of person-centered relational healthcare in all places where vulnerable care occurs. This inquiry further supports the work of critical reflection and education as healthcare providers learn about trauma-informed care, humanness of caring, supportive relationships, and therapeutic use of self. In research, this inquiry contributes to the epistemological value of arts-informed narrative inquiry in healthcare research, as well as the rich history of critical feminist theoretical perspective in qualitative healthcare research. It is my intention that the reflections inspired by this inquiry create ripple effects with my audience, all of you, as we move forward in a society where dignity and respect for humanity is upheld in every aspect of our lives. With this in mind, I thank you for joining me today, and I now invite you to share your reflections and questions with me. Thank you.